great to be with everybody here. Let's see, I'm a little bit taller sometimes. Is that okay for sound?
Yeah.
Okay, great. As a triple deke, it was very difficult to take a job at Duke. Someday I hope my father will start speaking to me again. But I did go to UNC, so that I think is good. So I don't know about you all, but our family got super obsessed with the Olympics, as we do every year. And I saw this picture. This is Cassandra Beaugrand. She's a triathlete, French triathlete that won the gold medal. And to me, sometimes lung cancer can feel like a triathlon. So you go swimming, you're running, you're biking, your chemo, your radiation, and your surgery. And this is the image that was displayed after Cassandra won the gold medal. But I think, as all of us are aware, it's what happens after you ring the bell, and what happens after you are, what happens after you cross that finish line. And so this was a picture that a very enterprising AP reporter captured of her immediately going through that tape. And it reminded me of really what my work has been, which is what happens afterwards. And this is Dr. Fitzhugh Mullen. He was a physician as well as a cancer survivor, and he started the National Coalition for Cancer Survivorship, which is now Cancer Nation. It was one of the first advocacy organizations that really focused on policy. And this is what he said in a 1985 paper when he sort of looked at what happened to cancer survivors after treatment. And unfortunately, I think that this statement really relates to where we are in terms of cancer survivorship today. These are my speaking disclosures, and this is sort of what I'm going to go over with you in our 20 minutes today. And I think it's really important. People ask me sometimes, why lung cancer survivorship and why now? And I think, as you all are aware, the survival rates for lung cancer are increasing at a higher rate and increasing to higher levels in women than men. But we are really accelerating the rate at which we are producing cancer survivors. So the deaths from non-small cell lung cancer fell 3% in the early 2000s, and now that's about doubling. So we're doing an excellent job of creating cancer survivors. And I want to emphasize that survival rates are increasing for all stages. So I tell a very self-depreciating story, which is difficult for a physician's ego, of probably about 4 years ago, it was 5 years ago now, a patient came in to me and had multiple brain metastases. We were going to treat him with whole brain radiation. He and his family asked, what's my timeline? What's my survival? I've got kids coming in from different parts of the world. And I gave him the 6 to 12 month, time frame. And he showed up in my clinic about a year and a half later and had been completely controlled on a new immunotherapy. And I saw him on my schedule and I was like, oh my gosh. And then I walked in and he gave me this big hug and said, bet you didn't expect to see me. And I was like, no, but it's wonderful to be surprised. And so that just showed me and humbled me that really it is very difficult to predict what our survival rate is going to be, not only for early stage patients, but also for advanced stage patients. Now this is where my passion comes in, and this is sort of what happens after cancer. So as you can see, this is from the Journal of Thoracic Oncology from 2012. I couldn't really find a paper looking at lung cancer symptoms after cancer that has been really updated and done a great job with a large number of patients in the past decade. But this is the best data we have. So each of these little dots shows a symptom. Each color represents a different symptom that patients experience after lung cancer. And the marks are at 1 year, 2 years, 3 years, 4 years, 5 years, 6 years, 7 years. So they ask patients every year, how is this symptom in your life? And as you can see, some of them, like hemoptysis or coughing up blood, were stable over time. But the things that got worse over time included pain, appetite, shortness of breath, and fatigue. And I think that rings true to my experience in taking care of lung cancer survivors as well. I will say that this after cancer really depends on specific factors related to you and your treatment. So sometimes it's kind of like, well, I'm having this and I'm having this, or why am I not having that, or you're having that. And it really is becoming more and more specific as our treatments get more specific. However, I think we're going to have to start building bridges because there are so many of these drugs that are being used in different disease sites. So it may not only be that a lung cancer survivor may be experiencing your symptoms, but you may reach out to a colorectal cancer survivor or a pancreatic cancer survivor or a head and neck cancer survivor where medications like Keytruda are being used. And I think we're going to have to start maybe grouping patients together based on their biology rather than just based on the location where the tumor is located. And I think that's an opportunity for survivorship because a lot of these drugs have the same side effects in patients. And in order to learn how to manage them and how to take care of people that are on some of these drugs long term, we're really going to have to start pooling our resources. This is just a representation of this. This is from Cancer Nation or Cancer Survivorship. And it talks about different symptoms that, for some reason, different symptoms that patients had during treatment and then after treatment is completed. And these patients, after treatment is completed, these are all comers. And as you can see, the side effects that patients report are very similar to those side effects that we saw in lung cancer survivors. And I would say that there's many reasons for side effects to happen. And sometimes I think that we are too quick to blame our oncology drugs for side effects. And we can be guilty of really focusing in on what we see in front of us, which is a patient with a malignancy, when actually you still are a whole human being. So oftentimes when patients come in and frustrated, usually from symptoms from their medical oncologist, definitely not from radiation. I start at the beginning. There's a lot of radiation oncologists in front. I start at the beginning and say, have you seen cardiology? Have we done a swallowing eval? Have you talked to our dietitian? So there are these other specialists we can start drawing in. In my opinion, we need cancer-focused specialists in each one of these areas. But there are people that we can start drawing in, and we need them to be involved in us and not just say, oh, that's just fatigue from your, Taxol, or that's just fatigue from your Keytruda. That's normal for a cancer patient. When, by the way, you're in florid heart failure and you need, a tune-up in heart failure. So I do think that it is not unwise when a new symptom happens or you don't seem to be getting better to sort of talk about, well, what if we pulled in an expert? And that leads me to my next point. So I grew up in Illinois, and the best Olympic team of all time is obviously the Dream Team, which is mostly made up of Chicago Bulls. And really, I think the relationship between the oncologist and the patient and their family changes as you move into survivorship. So at the beginning, it's this person that has all the information, they're setting the treatment plan for you, they're educating you about side effects, they're really kind of controlling your life and your schedule, and that is really the role of the oncologist. As you move towards oncology, without having, as my teenage daughter told me, a DTR, define the relationship talk. We don't have a DTR that says things are going to change. As you move into survivorship, the oncologist really moves back, but without telling you, you need to start moving forward, and there is a transition that happens where you need to move to a different care team. We do that terribly in medicine. There is not a good way to do that. And therefore, I really think it causes a lot of problems and a lot of miscommunication between doctors and patients. Well, I have the symptom. What does it mean? Why doesn't my doctor seem to care? All they want to do is look at my scan. And I think that is, you are having the correct experience. If you're having an experience other than that, grab onto the legs of that oncologist and don't let them go. But the normal experience in our training is to really focus on a follow-up visit is for us to monitor the effectiveness of our treatment. Are you having disease progression? Is your cancer coming back? To a lesser degree, we are trained on talking about your recovery from treatment, treating side effects, and then talking about treatment-related changes that can happen years later. It's just not a huge part of our medical training, which is really focused on the treatment of active disease. So, a follow-up visit may not include a discussion of how to manage your side effects. a promise of cure or a discussion of prognosis, coordination of care with your PCP, I mean, how mind-blowing would that be, or an explanation of your symptoms. And that is the reality of where sort of the oncologist framework is, again, just really focused on what is the state of your disease. We try to do these other things, but I think this is really something that the way that cancer care was set up over the past 50 years really did not focus on after cancer. It was just like, you're alive, you're doing great. And so I think that can lead to some disconnect between patients. And I found, this was the only picture I could find in someone that was in the LCI colors, so that's why I chose that picture. But it shifts really, and I want to empower you in this advocacy space to really think about, as you're coming into, or as you're feeling a change in a relationship, or you're not getting something from your doctor that you did before, to not be afraid to take that mantle on yourself, and you start becoming part of that survivorship advocate, rather than waiting for your doctor to address these things. Because I think as many people tell me, my doctor never says this, they don't talk about that, and in our brain it could just be like, oh yeah, well, your feet are swelling a little bit, that's not a big deal, but to you it could mean I don't get to walk with my grandson, or I want to garden. And to us, it's like, oh, well, it's not bad enough to give you Lasix, so, just move on with your life, It's not a heart attack, you're not going to go to the ICU. So I really do think that relationship changes and who's in charge changes, and we don't do sometimes a very good job of communicating that. So I just want to give you permission to go ahead and own that relationship. And I will give you these 3 phrases. These are my 3 phrases for patients. And one is, I need to tell you something that will help you take better care of me. That is a showstopper in a doctor's office that says, I need you to really stop what you're doing, look away from the computer, and this is something that we need to talk about. The second part is, I'm struggling, I don't know what to do, is there someone here who can help me? Sometimes, especially with the changes in medicine, we are all being asked to do more with less. We're asked to put patients on our schedule in places where there aren't any. Our staff is changing over all the time. People are worried about their grants. There's a million things coming at us. But just because that is on us as a physician doesn't mean that you as a patient don't deserve and need the attention to the symptoms and side effects that you're having. So that it may not be the oncologist that's sitting in front of you, but it may be a navigator. It may be somebody in integrative oncology. It may be a survivorship APP that you need to talk to. And so opening up that conversation that sort of says, hey, I can see you're busy. This may not be you, but who else can I be here? Even if, is it your nurse? Is it your resident? Who else can I talk to? And then the third phrase that I try to train my patients to use is, this is really important. I really need you to hear me on this. And that to us sometimes is a lot of what medical training has been compared to is shoving our heads underwater and feeling like you're drowning, because there's so much to learn in medical training, and it's just feeling like you're drowning and you stop asking for help. And so sometimes as doctors, we're going through all of the information you're throwing at us, and it's going through our filter, we're hearing it, but it's just not catching any red flags for us and something that we feel, not that you feel, but that we feel is important enough for us to order a test or change direction. So this is really, I think, a patient taking a flag and saying, hey, this is important, listen up, I need to tell you something. The other thing is managing uncertainty. So I think that as we move forward in these changing survival numbers, it was very easy to treat extensive stage small cell lung cancer 20 years ago when I started my career. No one survived. So the survival rate was, we're going to do the best we can, and we're going to try to give you the best life we can for as long as we can. But there was absolutely no concept of a long-term extensive stage small cell lung cancer survivor. Now, as we're moving forward, both doctors and patients, and talking to one of you gave me a great example of a doctor who had a really great conversation with a patient about this, said, I don't know. And so hearing that sometimes can be hard for a doctor to say, for us to say, I don't know. Not something that we say very easily, but also not something that patients want to hear. You want to know, is my cancer back or not? What are we dealing with here? What's the next step? Am I going to have this side effect with this next immunotherapy infusion, or with this next targeted therapy infusion? And sometimes the truth is we just don't know. but you have done uncertain things before. So as a patient, and I have to remind myself as a doctor of this sometimes when I can't give the thing to a patient that they desperately want, is that managing uncertainty is something that humans are not good at. We are still animals at our core, and we want to know sort of, this is that, right and wrong, black and white. But really, as we move forward in lung cancer survivorship, that is probably going to become way more gray than black and white. And so managing uncertainty should lessen over time. You've done all you can do, and you've done this before. So you've managed uncertain things before. For any moms out there who've dropped your kid off at kindergarten and been the creeper looking in the window wondering if they were going to do okay, and then they turn into teenagers and you're like, somebody take them, thank you. Definitely not trying to get those teenagers back. So I do think that there are things, especially with my chart and especially with the increase in communication that you have available to you, really calling your doctor is very important. If you have something severe, if there's a symptom that you have that's greater than 2 weeks that you really can't explain, or if you're on something for a symptom and that stops working. So I do think, again, these are things that patients can hang their hat on to say, this is important and this is when I need to call my doctor. And that's sort of where I'll end right now. This was Snoop in the Olympics, who I think did a great job. And I'm happy as you guys take your questions. These are my favorite resources. We're very fortunate in Charlotte and in Raleigh, as well as in Winston, to have great Livestrong programs. I always recommend patients sign up for that. Hirsch Wellness Network does a lot of online programs for arts, music, writing, journaling, Reiki. They just do a great job. And then my friend Julie does cancerdietitian.com, and she goes through evidence-based, all the questions that you have related to what I should be eating and whatever the latest fad, whatever your neighbor comes up to you and says you should be taking more turmeric or whatever, Julie is a really great resource to do that. So that's it for me, and I'm happy to take any questions. Oh, and this is how you can get a hold of me. I do a Substack that's all about cancer, and then I did a podcast about the beginning of the cancer movement and how we moved away from surgery to chemotherapy. That's called Less Radical. That's it. Yeah. I'm happy to answer any questions.
I have one. So a lot of hospitals don't have centers for survivorship and the types of resources that a lot of the larger hospitals may have. What is available? How can people reach out to kind of get that type of support locally?
For sure. Well, yeah, I'll do that. Yeah, you keep that mic. So I have found a really great resource is, page of tendency. Cancer Community has done a great job of bringing resources together. And I think hooking up with people like the Lung Cancer Initiative or Live Lung is another organization that is available. And I think just as Brad was talking about with screening, as you know, as we've discussed, the survival rate of lung cancer has been increasing, but that is not true in rural areas and especially in rural minority areas. So in those areas, lung cancer survivorship has actually been declining. And that speaks to lack of resources, which I think, based on some of the funding decisions that are being made in Washington, could become even more acute. But I do think that there is an opportunity for us to move forward in virtual options that are available. So any of those options that I showed you are all available virtually, and then I do just encourage you to reach out to Paige or Jenny or the Lung Cancer Initiative to just say, hey, I'm a survivor, and to connect with people. I think that's the great thing about resources like this and meetings like this. As a doctor, I mean, I go to doctor meetings and we talk about p-values and which survival is best, and doctors get up and argue about their studies. But sometimes it's just really helpful to come back and retouch the people that we're doing this for, and to look at our pharmaceutical partners. In my opinion, I think that pharmaceutical companies have a vested interest in cancer survivorship. There have been multiple studies now, phase 2, phase 1 studies looking at, for example, fiber in diets. There's this amazing melanoma study published at ASCO that just eating a handful of broccoli a day, basically that equivalent of fiber, increased the response rate to immunotherapy drugs by 75%. And that's based on the gut microbiome. So I think that the more people, from a capitalism standpoint, the longer you can keep people healthy and on your drug, like the more money you're going to make. And if that is something as simple as having a dietitian following your patients and helping them stay on this medication and having a better response rate. So I think that I think this is a great time to think about survivorship, and definitely as it relates to palliative care, which is just, I mean, hand in glove with what we do in survivorship as well. So that's what I would say. Any other questions or anything else I can? Well, thank you all. It's very energizing to be around you, and I appreciate your time.